Good morning. I'm Professor Salma Hadad, Department of Pediatrics, Baghdad College of Medicine. Today we will start the first lecture in childhood anemia. The objective of this lecture, first, to define anemia. Second, to list the general causes of anemia. Third, to list the signs and symptoms of anemia, outline the steps for diagnosis of anemia, and finally, we'll describe the clinical presentation and management of iron deficiency anemia in children. How we define anemia? Anemia can be defined as a reduction in hemoglobin concentration, hematocrit or packed cell volume, or the number of red blood cells per cubic milliliter below normal for age and gender specific value. Anemia is a sign of underlying disease, and the clinical presentation of anemia depend on etiology and pathogenesis of underlying disorder. If you have a test tube contains the blood and put it in centrifuge, then the lower part, as you can see here in this slide, contain the erythrocyte, which is the packed cell volume. Normally, it is around 46%. The upper layer contain plasma, the middle layer, buffy coat, contain leukocyte and the thrombocyte. In utero, the hemoglobin level is high because oxygen tension is around 65%. So the fetus need higher level of hemoglobin to deliver the oxygen to the tissue. But after birth, with the expansion of the lung and rise in saturation of oxygen to 100%, this level of hemoglobin will decrease and in the initial 6 to 8 weeks of life to reach a physiologic nadir of 9.5 gram per dl. Then it gradually increases to childhood level range between 10.5 to 14.5 gram per dl. What are the scenarios of a presentation in childhood anemia? Either a child is feeling well but found to have anemia or routine screening test, or a child who's tired and doesn't eat well, or a child who's being evaluated for other chronic problems and found to have anemia, or a child who's obviously pale, lethargic, and requires immediate assessment. What are the general causes of anemia? First, poor production of red blood cell due to nutritional deficiency, iron, folic acid, and B12. We know that these minerals are essential for bone marrow to produce red blood cell and other blood elements. Or there is a reduction in erythroid precursor due to infiltration of the bone marrow by leukemia or replacement by fat in aplastic anemia. Or there is ineffective erythropoiesis. Here the bone marrow is apparently active, doing more erythropoiesis to produce adequate number of circulating red cell, but it is ineffective erythropoiesis due to defect in hemoglobin with the decrease in lifespan of RBC, like thalassemia. The second cause is destruction of red blood cell in hemolysis. The third cause is loss of RBC in bleeding. How we approach a child with anemia? First, we should confirm the presence of anemia by using age and gender specific table. Second, by evaluation of red cell indices, the mean cell volume, mean cell hemoglobin, and mean cell hemoglobin concentration. Mean cell volume is the most useful blood red cell index, which enable classification of anemia depending on RBC size into microcytic, normocytic, or macrocytic. The third step, by assessing the white blood cell and the platelet count to know whether anemia is isolated or affection of other cell lines. The fourth step, microscopic examination of a blood film to assess the size, the color, and shape of RBC, also presence of abnormal cells like blasts and leukemia. The general symptoms of anemia are variable. Many children have no symptoms. That's why it's important for children to have routine blood tests. The other symptoms are due to reduced supply of oxygen to the tissue. This will lead to fatigue, dyspnea on exertion, fainting attack, palpitation, dizziness, and headache. In older person, they might develop heart failure, angina pectoris, or confusion. Other important points in the history, we should assess the patient history regarding diet, type, quantity of milk, ingestion of non-food items, what we call it pica, in iron deficiency anemia, medications, his activity level, acute or recent infection, or presence of chronic diseases. Family history is important, like ethnicity, anemia, jaundice, splenomegaly, gallstones, bleeding disorders, or history of transfusions. How the body adapts itself to anemia. Due to reduction in delivery of oxygen to the tissue, this will trigger a variety of compensatory mechanisms, like modulation of oxygen affinity due to increase of 2,3-biphosphoglykoside. And when this compound increases in RBC, it will decrease the affinity between our hemoglobin and oxygen to make oxygen more readily delivered to the tissue. The second mechanism, by increase the production of erythropoietin from the kidney, which is the main growth factor for red blood cell production. The third is redistribution of flow to benefit vital organs like myocardium, brain, and muscle on expense of skin and kidney. Increase in cardiac output is another mechanism, especially when hemoglobin decreases to less than 7 grams per dl. Clinical manifestation of anemia depend whether anemia is of rapid or insidious onset. When there is acute onset of anemia in cases of acute blood loss, this will lead to intravascular volume depletion. But when anemia of gradual onset, it is either mild, asymptomatic, or simply manifests as a slight fatigue and pallor. But if more severe, then the child will present with exertional dyspnea, tachycardia, palpitation, angina, fainting, and signs of heart failure when hemoglobin reduced to less than 5 grams per dl. Other signs related to cause of anemia is the presence of jaundice, which indicate hemolysis, splenomegaly, seen in inherited hemolytic anemia like hereditary spherocytosis, malignancy, acute infection, or hypersplenism secondary to portal hypertension. Presence of petechial rash indicate multiple cell lineage involvement. The age-related differences in incidence of anemia. In a newborn infant, usually they have acute anemia. Most commonly occurs due to significant blood loss from birth trauma or blood exchange or bleeding from the placenta. In isoimmune anemia, when the mother develops antibody, it crosses the placenta and causing hemolysis in the child RBC. Or abnormalities of fetal hemoglobin, which may cause anemia, like deletion of alpha-globin gene mutation causes anemia in a newborn. In infancy, nutritional anemia is the most common type of anemia due to associated rapid growth, necessitating increase in red blood cell mass as well as dietary adjustment. In early childhood, with exposure to new infection in school age years, then anemia of acute infection is the most common in this period. While in adolescence, it is a period characterized by rapid growth and vulnerability to nutritional anemia. They are more likely to develop an anemia, as well as a blood loss with heavy menstruation, which can be observed in adolescent females. We will talk about nutritional deficiency anemia in children, which is due to deficiency in one or several nutrients. The main nutrient involved in synthesis of hemoglobin, as we mentioned, are iron, folic acid, and vitamin B12. Iron deficiency anemia in public health terms is by far the first cause of nutritional anemia worldwide, responsible for 30% of causes of anemia in children globally. While iron and folic acid deficiency is less widespread and often associated with iron deficiency or occurs in patients with hemolytic anemia, vitamin B12 deficiency is more rare. Causes of iron deficiency, either poor intake with inadequate dietary iron. This is unusual before 6 months of age, but becomes common at age 9 to 24 months due to consumption of large amount of cow milk and food which are not supplemented with iron. The second cause is malnutrition, for example, children with a kwashiorkor. The second major cause of iron deficiency is increased demand. This is especially in low birth weight and the preterm baby. As we know, the transfer of iron from the mother to the fetus occurs in the third trimester, and those who are delivered preterm, they have low body iron stores, and their rapid growth makes them vulnerable to development of iron deficiency anemia. The third cause is a blood loss from GIT, like peptic ulcer, mycodiverticulum polyp, or inflammatory bowel disease, or hookworm infestation as an important cause of iron deficiency, like ankylostoma duodenale, or bleeding from other sites outside GIT, like nose, lung, kidney, or trauma. The fourth cause is malabsorption in celiac disease and partial gastrectomy. Clinical features of iron deficiency. First, the general signs and symptoms of anemia, we mentioned already, or other signs and symptoms specific to iron deficiency anemia occur in patients with long-standing deficiency. Iron is essential for integrity of epithelial tissue in the body, especially the GI tract, and iron deficiency will lead to changes like nail flattening and koilonychia, causing concave nails, sore tongue and papillary atrophy, or angular stomatitis, painful cracks in the angle of the mouth. The most important side effect of iron deficiency is psychomotor delay and behavioral problems in young children, because iron is important coenzyme for cytochrome necessary for neurodevelopmental function. And those children who have long-standing iron deficiency anemia will develop behavioral problem and psychomotor delay, and also they are liable to have short attention span, lack of concentration, notice while the child is at school. Other signs and symptoms of anemia are due to underlying cause. In this picture, you see angular stomatitis, painful cracks seen at the angle of the mouth. Another picture for pale, smooth, burning tongue, and iron deficiency due to alteration in tongue tissue. In this picture, you see koilonychia or spoon nails. Diagnosis of iron deficiency by doing a complete blood count, which show low hemoglobin, low MCV, MCH, and MCHC. In the blood film, we'll see microcytic hypochromic RBC. The other confirmatory tests are low serum iron, increased total iron binding capacity. We know after absorption of iron from the GIT, it will bind to specific plasma protein called transferrin. Normally, it is 30% saturated with iron, but in iron deficiency anemia, this saturation will decrease to less than 10%, lead to an increase in iron binding capacity. Serum ferritin is the most useful test in iron deficiency anemia. In this slide, you can see a decrease in mean cell volume, mean cell hemoglobin, the mean cell hemoglobin concentration, normal or low, decrease in iron, as we said, increase in total iron binding capacity with the decrease in the transferrin saturation to less than 10%, also decrease in ferritin. In this picture, you can see normal red blood cell on the left side, while on the right side you see hypochromic microcytic RBC and iron deficiency anemia. Treatment of iron deficiency is by using oral iron, and here we should give iron until we have normal level of hemoglobin, and then we replace iron in total for 8 weeks after having normal blood value to replenish the stores of the body. We should establish and retrieve the cause of anemia like GI blood loss. The therapeutic dose should be calculating in terms of elemental iron with total daily dose 6 milligram per kg divided in 3 doses per day. Response to iron is an important diagnostic and therapeutic feature in iron deficiency anemia. The response to oral iron is usually rapid, and the retic count should rise in 5 to 10 days with an increase in level of hemoglobin by 1 gram per day or per week. If there is failure to respond to oral iron therapy, this either the child has a wrong diagnosis like other causes of anemia, like beta thalassemia minor, which we will mention it later, or he has an inadequate dose of iron, or non-compliance when the child doesn't receive the prescribed medication, or he has malabsorption or continuous bleeding in case of intestinal or pulmonary loss, or with menstrual period in adolescent girls, or when iron is given in form that is poorly absorbed. Usually iron is prescribed in ferrous form because the ferric form is not absorbable, or the child has severe infection which prevents utilization of iron. The parenteral iron therapy in form of iron dextran is an effective form of iron indicated for children with poor compliance, intolerance of oral iron, or those who have severe bowel disease, chronic hemorrhage, or acute diarrhea disorder. However, the rise in hemoglobin concentration is not faster than with oral iron therapy. Please keep this fact in mind. Prevention of iron deficiency by encouraging breastfeeding, especially in the first 6 months of life. Beyond 6 months, we should add iron supplementation in form of iron fortified formula and iron fortified cereal early with solid food in the first 12 months of life, and also avoid giving the child cow milk, especially in the first year of life. Now we talk about beta thalassemia minor or Tourette, which is misdiagnosed as iron deficiency anemia. In this case, the person is asymptomatic with normal physical examination, discovered on routine blood testing by having a slightly reduced hemoglobin, basophilic stippling, which is blue dots present in the RBC, occur in these cases. He has low mean cell volume and normal red distribution width. It is discovered in family investigation or when there is family history of heterozygous or homozygous beta thalassemia, or in couples before marriage. It is confirmed by hemoglobin electrophoresis demonstrating the slightly decreased hemoglobin A 90 to 95% typically, with increased hemoglobin A2 to more than 4%. Normally, hemoglobin A2 is less than 3.5%. In this slide, you can see if both parents are carrier for beta thalassemia trait, they will have 25% chance of having a child with Cooley's anemia or beta thalassemia major. and 25% of children are normal, while 50% of children, they will have a beta thalassemia trait like their father. That's why, parents, sorry. That's why it's very essential to check hemoglobin electrophoresis for A2 before marriage. Screening here is vital. We will end with this slide. We'll continue next lecture, and thank you so much.